I'm Josh McDonald,
Hi, I'm Emily Kerr.
and we are Hand Therapy Academy. So, Emily's joining us again as one of our staff members, asking us a couple of questions. So, Emily, what question do you have for us today?
Yeah, my question for you, Josh, is what are your thoughts on the plan of care for patients after a humeral fracture that present with a radial nerve palsy?
Yeah, so let's start with the caveat that if you have any patient with a humeral fracture, specifically anything managed conservatively with no ORIF, no hardware, that we need to be super careful. And every time I begin and end a session, I need to have them put their hand flat on a surface and do thumb retropulsion to make sure that that they still have radial nerve, motor nerve function. Um, if at any point they don't, stop what you're doing, send them back to the doctor. Let's talk about the patient where we know they have a radial nerve injury. Maybe it's from a gunshot wound to the shoulder. Maybe it's from a humeral fracture. Maybe it's from, I had a patient with I'll say botched, maybe, distal bicep rupture repair. And basically the radial nerve was just pinned under the hardware. Um, and, and so we started this whole plan, right? So Emily, someone like that pops onto your doorstep. What's the what's the first thing? What's the not first thing? What's your first thoughts when they come in for a session? Like day one, we've got a radial nerve palsy. You're making all the splints. What's your expectation for them moving forwards?
I think that's what I struggle with because we do have a fair number of patients right now, actually, that have had the ORIF or we that come to us. We already know that they have a radial nerve palsy, and I've made them the splint to help with the wrist extension and digit extension. And we're working on range of motion, scar sensitivity stuff, functional strengthening, and even strengthening those tendons for possible tendon transfer. But like, at what point? I guess I feel like the length of plan of care seems to be so long before any intervention is done on the surgeon side of things.
Yeah. And that's something that I feel like most of the surgeons, PAs, providers are really reluctant to jump in and do anything because who knows, maybe it will spontaneously heal as sometimes does. And we don't want to have done something that you can't reverse, that locks us in, that says like, oh, we did this big tendon transfer, but we didn't need to, or we went to do nerve surgery and all that was needed was this little thing. So we find in our clinics, it's always a wait and see. Wait and see, wait and see, wait and see. Every month they go in, they're told, let's wait because it'll take a while. And then every 2 months, and then every 3 months. And before you know it, we've reached a year. We're burning through visits. We're using up copays and they reset deductibles. And the doctor just keeps saying, go back into therapy. But at some point, the muscles are wasting away. So we try to do things like e-stim to let's slow the wasting. We try to get them a home e-stim unit and say, put this on extensor bundle. Let's get as much of that muscle activation as possible so that we slow, if not pause, that wasting process. We try to get them functional with things, but the doctor says you got to keep going to therapy. And I think sometimes the surgeons are at a loss and we are their blank check to write. We are their escape to say, like, therapy is going to help you because I can't do anything. I don't know anything yet. Go to therapy. Therapy's the default answer for lack of anything else. An article came out maybe 6 months ago, and they talked about the expected return if you're going to see spontaneous recovery. And it does happen. From the date of injury, you should see a slow but progressive return that ramps up over time so that by the 6 to 8 week mark, you have a noticeable change in manual muscle testing grade based on compared to initial eval. So within 6 to 8 weeks, maybe you were 0 and now I'm a 1. Maybe you were a 0 and now I'm a 2 minus, but I should see something by 6 to 8 weeks. And if you don't, your chances for spontaneous recovery are really low, and it's time to go look at options.
If you, in your experience, if you have the patient where you've done a progress note, maybe you've done two progress notes, so maybe at that 6 to 8 week mark, and Um, you're noticing everything is pretty much staying the same. What options do you have at that point? If they go back to the doctor and the doctor says, nope, keep going, like keep waiting. But as a therapist, I feel like we kind of know like it's not going to regenerate. So
Yeah. I feel like we recently learned this by talking to one surgeon about some options for a patient of ours. And the theory about waiting says if it's going to spontaneously return, we don't want to have done tendon transfers too early. So let's wait until, honestly, they're waiting until the 12-month mark in our area. Sometimes 9 months, but they're kicking it down the curve to 12 months. But if that was something that just needed a decompression on the nerve, or needed a neurolysis, cleaning up scar tissue around a nerve, or maybe it needed a nerve graft, that nerve surgery option has to be done before 9 months. Because if you wait until after 9 months, the muscles have so wasted away, there's nothing there for the new nerve, the cleaned nerve, or the improved nerve to actually activate. So it's this two-sided coin. You don't want to do tendon transfer too early, but you have to send them to someone that says, like, well, let's look at the nerve side of this, because we're not just sitting dormant and waiting on our front porch to see if muscle spontaneous. Let's look at the nerves. And so I feel like it's about knowing the providers in your area. And if you've got an orthopedic doctor who says, if it doesn't spontaneously return, if not A, then B, we do tendon transfers. Well, let's look at C, because there's another option in here. So we have a list of providers to say, let's send you to this person to say, let's look at the nerves. We had this patient go for an EMG, and they did an EMG on the wrong nerves. They did median and ulnar and said, you look great. And we're reading the EMG saying they didn't even do radial nerve, and the provider missed it. So we wanted to send her to someone who had the nerve specialty to say, should we do a neurolysis? Should we do nerve grafting, nerve transfers? Should we do something else so that we don't get to this, something to preempt the option B, to say, you don't need to do a tendon transfer. Nerve transfers are kind of the direction we're headed. But we know certainly by week 12, it's either going to come back or it's not. And if you have zero, if you are at manual muscle test 0 out of 5 by 3 months, it is extremely unlikely that it's going to spontaneously recover at any point after that. It's just not going to happen.
yeah, and I feel like as a therapist, sometimes like going throughout that waiting period can be a little frustrating because we want the patients to get better. And with a radial nerve palsy, we see how limiting function wise that is, especially when it's the dominant hand that's affected. And so seeing the patient, 2, 3 times a week over time can feel I don't know, kind of sad, I guess, in my opinion.
Yeah. And defeating. And the patients feel that too. And it's tough because we want to be encouraging for our patients. You're here to get better. You're not here to tread water. We're not supposed to do maintenance in our notes, right? We're not here to tread water. There's times when we're like, if I'm seeing a patient with maybe Parkinson's or something, I'm trying to slow the progression of things. That's fine. But here it is so hard to not to try to stay positive and with that patient knows, like, this is getting worse. Like, I've got nothing. My arm is getting smaller. I can't do anything. I need people to do things for me more and more now. That's really tough. It is really hard. And so we'll drop them maybe 1 time a week and say, like, if you feel like there's a functional need, we can jump up to 2 times a week. But usually we can kind of keep an eye on things. But sometimes the doctors are sending them, you need to go 2 times a week. And they're like, I'm here for it. So they want to keep coming. We'll do everything we can. But we try to keep it as functional as possible. Get fun, get creative, have them use that hand with and without the support and of the splint as much as they can.
Yeah, that makes sense. Thanks for sharing.
Yeah, yeah. It's a tough diagnosis. And I feel like we don't always have much power in the dynamic, much say in the dynamic, because it's all resting on the surgeon who's saying, sit and wait. And sometimes the patients only want to listen to the one with the white coat and the stethoscope. And they're saying, like, that person knows. That's a PA. That's a PA that isn't really sure. And maybe it's even a surgeon who's an orthopedic looking for tendon transfer and trying to hold off on doing that. Maybe gently and subtly make that recommendations for a second opinion, like that you should never hesitate to get a second opinion if you want one. There's nothing wrong with a second opinion, and any provider who tells you otherwise should be questioned. But it's hard to suggest that to therapists, or excuse me, to patients sometimes, because we have a relationship with these doctors. And I don't want to undermine them and be the one that says you should go talk to this doctor. But it's in my patient's best interest. That's a possibility. And maybe talk to the doctor and say, like, hey, what do you think about sending them to Dr. Larson? Because Dr. Larson does this whole nerve thing on the front end. What do you think about that? And so it can be a way to keep that open conversation.
Yeah, that conversation is important for sure.
Yeah. All right. If you guys have any questions about this or anything else, reach out to us on our email, info@handtherapyacademy.com, or on our social media accounts at Hand Therapy Academy.